We are live now. With all your permission, I'm starting this session.
Okay.
Good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Professor Dr. Bharat J. Parmar, sir. Sir has done MBBS, MD, DHA, FAIMS, and Professor and Head of Pediatric Department in Zydus Medical College and Hospital, Dahod, Gujarat. And today, sir is going to discuss on a topic, management of pediatric headaches. Let me tell you overview of the topic. Headache is a common complaint in children and adolescents and many times lead to much anxiety for the particular and the parents. The differentiate between primary headache disorder and secondary headache disorder, clinician must comprehend the methodology used to evaluate headache. To know more about this topic, I would like to invite sir and hand over this session to sir. Sir, over to you. Kindly proceed from here.
Yes. Good evening to all. First of all, I am very thankful to MedTalk and IJCP group for giving opportunity to highlight my views for the management of headache in children as well as the adolescents. Headache is a common but relatively under-recognized problem in children to inability to complain or describe it. Head banging is an important indicator of headache, and recurrent persistent headache is a cause for concern and needs investigation. Headache is common complaint also in adolescent. It can be greatly influence the quality of life and could be pointed towards a serious intracranial pathology or a stress. Next. Sources of headache. Intracranial headache due to cerebral or dural arteries pain due to dura mater at the base of brain. So there's a sources of pain due to headache. First is intracranial, cerebral or dural arteries, dura mater at base of brain, large vein, and the venous sinuses. An intracranial cause, there's a source of pain due to headache. It is cervical roots, cranial nerves, and extracranial arteries, and the muscle attached to the skull, periosteum, and sinuses. So these are the source of pain due to headache, intracranial as well as extracranial. Next. Different types of headache. There's a cluster headache, indomethacin responsive headache, chronic paroxysmal hemicrania, hemicrania continua, benign exertional headache, chronic low-grade headache, analgesic rebound headache, caffeine headache, and post-traumatic headache. So these are different varieties of headache. Next, tension headache. Also, headache associated with the drugs and foods. There is food additives and marijuana, and headache and systemic disease. There is connective tissue disorders, hypertensive vasculitis, and hypertension. Pain from other cranial structures. There is eye strain, episodic tension headache, and sinusitis, and temporomandibular joint syndrome, whiplash, and other neck injury, and seizures headache after this epileptic convulsion. What is the classification of headache? Headache can be classified as a primary and secondary headache. Primary headache has no identified etiology, while secondary headache is a part of symptomatology of other disorders like trauma, vascular cause, infection, tumors, etc. Primary headache is more common during adolescence. Based on their temporal pattern, headache can be classified acute headache, acute recurrent headache or episodic headache, chronic non-progressive, and chronic progressive headache. Acute recurrent and chronic non-progressive are commonly due to primary headache disorders. What is the various etiology of headache? Acute headache etiology is febrile illness and intracranial pathology. There is a meningitis. Acute recurrent headache due to migraine, tension type headache, and cluster headache. Chronic non-progressive headache due to chronic migraine, muscular cause, hypertension, and chronic sinusitis. Chronic progressive headache, there is an intracranial cause, there is a space occupying lesion, and new daily persistent headache, it is due to post-traumatic stress or CSF leak. So these are the various etiology for headache. Diagnostic criteria for headache have been revised and published in the International Classification of Headache Disorders, third edition, beta version, ICHD 3 beta. There is a primary headache. Primary headache include migraine, tension type headache, there is TTH, and trigeminal, this autocephalgia, there is a cluster headache, and characteristic feature of different types of primary headache. There is a migraine. The pain description in migraine, pain is unilateral, throbbing, pulsating, moderate to severe, and worsen with exercise in migraine. And associated symptoms in migraine, photophobia, phonophobia, nausea, vomiting, with or without aura. Tension type of headache, TTH. The pain description in case of TTH, the pain is bilateral headache, is a pressing or tightening headache, mild to moderate, and does not worsen with exercise. And this tension type headache lasts 30 minutes to 7 days. Associated symptoms in nil in case of tension type headache. Then cluster headache. Cluster headache, pain description, there is a unilateral around the eye, unilateral headache. It is severe, excruciating, deep, and lasts for 15 to 180 minutes. And associated symptoms in cluster headache, there is autonomic features, there is tearing, congestion in eye, pallor, sweating, rhinorrhea, and restlessness and agitation. Next, etiology of headache. Headache may be organic or functional. Recurrent headache is more likely to be organic in preschool children, while psychosomatic headache are more common in older children. Tension headache is the commonest cause of headache in school-age children. Causes of headache in children. First is a tension or stress headache due to anxiety and stress. Second, due to occipital neuralgia, there is an unstable atleto-axial joints. Vascular headache, there is a migraine. Then intracranial pathology due to increased ICP. In case of hydrocephalus, intracranial space of a lesion. There is a tumors, tuberculoma, and NCC, an infection, the meningitis, and encephalitis, and hydrocephalus, pseudotumor cerebri. These are the causes of headache in children. Cerebrovascular malformation, hypertensive encephalopathy, post-traumatic injury, extracranial headache due to ophthalmic. There's a refractive error in children. ENT due to chronic sinusitis, and the dental problem and headache, and psychogenic headache, it is due to conversion reaction or depression. So these are causes of headache in children. Other cause headache in lead poisoning, also due to premenstrual syndrome. And last, not the least, there's no cause found, there's an idiopathic headache. How to diagnose? A careful history and thorough neurological examination often enough to differentiate benign headache from the potentially pathological cause of headache. The location and character of the headache, along with other characteristics. There is a mode of onset, frequency of attack, diurnal variation, and precipitating and relative factor in case of headache. Presence of associated symptoms, vomiting, visual problem, and other neurological symptoms. The baseline examination for a refractory error and ENT checkup, including next sinus X-ray in case of ENT checkup, and ophthalmic examination for the refractive errors. Next, and neuroimaging with CT scan or MRI scan indicated only in children with abnormal neurological signs, recurrent recent behavioral changes, predominantly morning headache with vomiting. So when there is abnormal neurological signs, recent behavioral changes, predominantly morning headache with vomiting, on fundus examination papilloedema associated with seizures, there is a possibility of AV malformation, and cluster headache or severe headache during sleep, do CT scan or MRI. There is a neuroimaging for headache. Important cause of headache in children. Tension headache are related to the periods of anxiety and stress at home or school, which may unconsciously produce constant isometric contraction of face muscle and the neck muscle and tension headache. So tension headache are typically dull aching. It is diffuse and variable location, more common after or during the school hours, and the tension headache not associated with nausea, vomiting, and other symptoms like migraine. Persistent spasm of neck muscle indicate possibility of unstable atlantoaxial joints. There is occipital neuralgia in some cases, and diagnosis of tension headache depend on careful history taking, including psychological evaluation and exclusion of other causes of headache. Most of the cases may be treated with mild analgesics and behavioral therapy in case of mild headache. Organic headache. Organic headache, there's a traction headache. It indicates raised intracranial pressure leading to traction or a tension on a cerebral vessels and dura-mater. These headaches are typically common in early morning, localized in frontal or occipital region, worsen after any activity that further raise intracranial tension. There is a coughing or sneezing, and associated with projectile vomiting, behavioral changes, and papilloedema. So these are all symptoms. There is a organic headache due to CNS pathology, and the diagnosis and treatment depend on individual causative condition. It is more in the morning, in a frontal or occipital region, worsen with coughing and sneezing, and it associated with projectile vomiting, behavioral changes, and on fundus exam papilloedema in case of organic headache due to raised ICP. Next, ophthalmic headache caused by uncorrected refractive error often distinguished from tension headache. So mostly it is due to eye strain during the school hours or after in evening there is a headache. This case is usually present with a dull aching frontal headache, more common in evening, and frequent rubbing of eye due to ophthalmic headache. Sinus headache. Sinus headache due to chronic ENT problem are common in older children and typically become more prominent in a head-low position like during relaxation. And localized sinus tenderness. There is a tenderness of frontal sinus or a maxillary sinus, and sinus X-ray and abnormal ENT finding can be this etiology leads to headache, ENT etiology, sinusitis. Migraine. Migraine is defined as a recurrent headache with symptom-free interval and at least 3 of the following 7 associated findings. So in case of migraine, positive family history, probing character of headache, unilateral headache associated with nausea, vomiting, abdominal pain associated with visual, sensory, or motor aura, and relief following the sleep. So when there is a 3 of these following 7 finding, then there is a diagnostic criteria for migraine. Unlike general impression, migraine is not uncommon in children, with estimated incidence in children 4 to 5% in school age group children, there is a migraine. The exact cause is unknown, but an inherited predisposition to vasomotor instability is an important underlying factor and lead to migraine. So migraine without aura and with aura. Without aura, with aura, there is a typical brainstem. There is a hemiplegic migraine or a retinal migraine. Sometimes there is a migraine is chronic, and also there is an episodic syndrome associated with the migraine. So migraine without aura, with aura, hemiplegic and retinal migraine. Sometimes there is a chronic migraine, and sometimes there's an episodic syndrome associated with migraine. Classification of migraine. With aura, typical aura, it has at least 2 of the brainstem symptoms, which include dysarthria, vertigo, tinnitus, hyperacusis, diplopia, ataxia, and decreased level of consciousness without motor weakness. Hemiplegic migraine. Here the aura consists of fully reversible motor weakness less than 7 days. and fully reversible visual, sensory, and speech and language symptoms lasting for 5 to 60 minutes. It is reversible. Retinal migraine. The retinal migraine, the aura consists of fully reversible monoocular positive or a negative visual phenomena. So what is the difference between adult and pediatric migraine? In adult, the site is unilateral headache. In pediatric, can be bilateral. In adult, the site is frontotemporal, while in pediatric, it is a bifrontal. And duration of headache in adult, 4 to 72 hours. In case of pediatric migraine, 2 to 72 hours. In case of adult migraine associated symptoms, photophobia, phonophobia, nausea, vomiting, with aura or without aura. In pediatric migraine associated with nausea, vomiting, more prominent. And in adult migraine, visual aura, there is a fortification, spectra, shimmering, scotoma, involving only half of the visual field. While in case of pediatric migraine, there is a photophobia is more common and randomly dispersed in the field. Complication of migraine. So which are the complications? Status migrainous. There is a debilitating migraine lasting more than 72 hours. Second is migrainous infarction. It is more than one migraine or a symptoms with an ischemic brain lesion in a appropriate territory. Migraine aura. Seizures triggered by attack of migraine with aura, auditory visual at bottom. And trigger seizures occur during or within 1 hour after the attack of migraine with aura. Episodic syndrome associated with migraine is a cyclical vomiting syndrome, abdominal migraine characterized by recurrent abdominal pain and benign paroxysmal vertigo. These are the episodic syndrome associated with migraine. Migraine treatment modalities. So, higher level 1, in first level, treatment of migraine, there is a lifestyle modification, SMART 5. Lifestyle modification, there is a sleep, there's a good sleep hygiene, meals, regular healthy meals, hydration, limit caffeine intake, regular exercise, and relaxation, stress reduction, and avoid triggering factor cause migraine. In a level 2 care, in case of migraine, there is an integrative therapy, there is a behavioral therapy, and nutraceuticals. And level 3 care, in migraine, there's a pharmacotherapy. It is abortive and preventive therapy in level 3 care, pharmacotherapy in migraine. In fourth level, other treatment of migraine, there is a onabotulin toxin A. So in case of migraine, what you should avoid? Avoidance of precipitating factor. There is a stress, fatigue, anxiety, hunger, blinking, bright light, loud sound, and probably certain food should be avoided. There's a Chinese and spicy food and chocolate in case of migraine. Management of acute attack with common analgesic, paracetamol, and ibuprofen with or without antiemetic. There is a chlorperazine or metachlorpropamide. Rizatriptan There's an oral drug, there's a 5 milligram per dose. It is a 5-HT agonist, may use in children more than 5 years with severe refractory attack of migraine. There is a rizatriptan 5-HT agonist. IV sodium valproate 50 to 20 milligram per kg over 10 minutes has been used in adolescent with intractable attack of migraine, sodium valproate in adolescent. Prophylactic therapy for very frequent and disabling attack is not standardized in children. It includes propranolol 0.3 to 1 milligram per kg BD, valproic acid 10 milligram per kg BD, flunarizine 5 to 10 milligram OD, and amitriptyline 1 milligram per kg OD, or drug orally, and orally also cyproheptadine. There is 0.1 to 0.2 milligram per kg BD used in younger children. Nutraceuticals, there is a riboflavin 25 to 400 milligram per day. Coenzyme Q10 1 to 2 milligram per kg per day has also shown promising results. And therapy should be continued of these nutraceuticals 4 to 6 months before tapering. And behavioral management and reassurance, if needed, in the most of stress cases, there's a tension syndrome, tension headache. So what is specific drug in migraine in adolescence? There is a triptan. Triptan, there is a sumatriptan. When you give in 10 to 17 years adolescents, dose orally 50 to 100 milligram and intranasal 10 milligram. Rizatriptan, if you give in more than 6 years child, oral 5 milligram, when the weight is less than 40 kg, and 10 milligram when the weight is more than 40 kg. And zolmitriptan, you should give more than 12 years children orally 2 to 2.5 to 5 milligram and intranasal 5 milligram or 10 milligram per day. The almotriptan, more than 12 years per oral 6.25 to 12.5 milligram, and sumatriptan or naproxen, there is a 10 milligram to 60 milligram, maximum 85 milligram. So triptan in case of migraine in adolescence. And SAIDs, these are used in mild to moderate headache. And commonly drug used are ibuprofen 10 milligram per kg per dose and paracetamol 15 milligram per kg per dose and naproxen 5 to 7 milligram per kg per dose. And onabotulinum toxin A, it was approved by FDA for a use of chronic migraine in adult. However, experience on its use in children is limited and few studies shows beneficial effect in a pediatric patient with onabotulinum toxin A. Red flag sign in case of secondary headache. Which are the red flag signs? Early morning headache or vomiting and awaken patient from sleep. Recent onset or severe headache. Change in quality and frequency of headache. It is occipital headache, progressive headache, coexistence of convulsion, seizures, change in personality, behavior, worsening school performance, and worsening with cough and Valsalva and symptoms of systemic disease. So, abnormal neurological examination and fundus examination, abnormality in growth and puberty, hypertension, and not responding to conventional therapy. So, these are all secondary headache. Algorithmic approach to an adolescent with headache. So, first, history, characteristic history, triggering factors, aura, associated symptoms, medication, family history, and comorbidities in case of adolescent headache. And this HEEAD triple S, there is a anxiety, depression, stress or pressure factors, diet and sleep, media use, and substance use. On examination of blood pressure and skull circumference, growth centile growth monitoring, body mass index, and also monitoring for puberty. Neurocutaneous marker, ENT checkup, eye checkup, and dental checkup. Mental status examination, there is a psychosomatic evaluation and neurological examination and red flag sign. First history taking, then examination, then red flag sign in case of headache in adolescents. Comorbidities, there is a primary headache, likely psychological evaluation considered when there is a secondary headache. Consistent with diagnostic criteria is there is no psychological event when there is a organic headache. When there is a secondary, there is a imaging, investigate, and treatment accordingly. So unilateral pulsating or bilateral pressing on psychological evaluation. Primary headache, unilateral pulsating, moderate severe, nausea, vomiting, photophobia, phonophobia, and migraine. While in case of psychological evaluation, in case of tension type headache is a bilateral pressing, mild to moderate, and no vomiting. This is tension type of headache, TTH. So migraine, there is acute treatment, there is NSAID, there is a paracetamol and brufen and triptan. And in tension type headache, preventives treatment is if indicated. In case there is a healthy lifestyle and relaxation technique psychotherapy, lifestyle modification. So in TTH, there is a therapy for 4 to 6 months. And wean and stop if it is headache is less, one headache frequency per month. So today's lecture concluded remarks, headache in pediatrics. Primary headache is more common than secondary headache during adolescence, with migraine being the commonest. Evaluation required detailed history and HEEAD triple S screening and physical examination to differentiate primary from more serious secondary cause of headache. Treatment of migraine should be individualized based on a individual and headache characteristics. Secondary headache need detailed evaluation with imaging CT scan and MRI and other investigation. Thank you.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participants who have joined this session. Sir, we have received some question from the participant end. If you allow, can I take this question with all your permission?
Yes, yes.
I can see the first question is, what is the role of genetic in the etiology of pediatric migraine headache?
The role of genetic.
Let me repeat the question, sir. The question is
So one
that
of the criteria of diagnosis migraine in children or adolescent, there is a family history. If there's a family history of this migraine is there is a possibility of migraine in children or adolescents. So definite role.
okay, sir. Thank you so much for answering it, sir. Moving forward, I can see there is another question. What is the role of cortical spreading depression in the pathogenesis of pediatric headache?
Coexisting depression.
Exactly, sir.
So in
Cortical
case of
spreading
this
depression.
tension type headache, TTH, so there is a possibility, it is a mild to moderate pain and no other associated vomiting or any, but it associated with the depression. So there's a psychosomatic evaluation is important to rule out this tension type headache due to depression.
Okay, thank you so much, sir. I can see there is a couple of questions. We will be taking last two questions for the today's session. The question are, what are medications selected for the treatment of pediatric headache symptoms?
In pediatric headache,
Symptoms.
pediatric headache, it is mostly it is in case of pediatric, in mild to moderate headache, right? So use this paracetamol 10 milligram per kg and ibuprofen. So analgesics and anti-inflammatory drug used for the pain headache in children when there is a mild to moderate.
Okay, thank you so much, sir, for answering it, sir. We will be taking last question for today's session, and the question is, what is pediatric chronic daily headache treated?
Mostly if there is a, when you rule out this migraine, the possibility there is a one terminology or types of migraine, it is a chronic migraine. So I already suggested all the management of this drug by migraine. So use this drug for the migraine for a long period.
Okay, thank you so much for taking out your time once again, sir, and making this session wonderful, sir. And it was a really wonderful presentation from your end. And which is a topic which should be much discussed and which is common nowadays as the school student and all the child face this problem, sir. And it should be discussed, right, sir? And I hope that all the participant has viewed this. As there is no more questions, sir, shall we conclude this session with all your permission?
Okay, thank
Okay,
you.
thank you so much, sir. And once again, thanks for your time, sir. And hope to see you again with different topic. Till then, take care.